Thanks, John. I appreciate the introductions. And today what we're going to be doing is actually taking questions from all of you from across the country. And actually we have one question that's in Australia. So I love this. You've indicated what you're interested in, and that's what we're following up on. The first question is from Iris, Puerto Rico. Are mood swings such as anger, jealousy, and depression part of the condition? And how do we manage the problems they cause? Either one of you.
Sure. Mood swings is a term that I hear about a lot in working with patients. I'll hear mood swings described, and I think it's very important to know exactly what the swing is to and from. And so what I think is really common in Parkinson's disease is for people to be maybe at a kind of a normal calm state and then become quickly anxious or irritable or perhaps even a little bit nasty or angry. And when people have depression on board and anxiety, their ability to deal with the frustrations and challenges of life, and especially life with Parkinson's, is reduced. And so to that extent, these mood swings are not so uncommon. And it's hard to know what someone is just sitting there thinking about. And so you might ask a relatively harmless question and see that they all of a sudden get real snappy and short. And with depression, that is not such an uncommon reaction. The other type of mood swings that we'll hear about in psychiatry are more associated with bipolar disorder. And briefly, bipolar disorder is where a person may be calm and then perhaps get very happy, really have a big expansive mood, and then it kind of builds to a peak, and then there's a big crash. Bipolar types of mood swings are really not common with Parkinson's disease. It doesn't mean that they can't happen at the same time, but it's not so common. And certainly with those more severe mood swings, you're definitely going to want to get some help from a psychiatrist. A psychiatrist would really need to be involved with that. And certainly anytime that these reactions are involving anger, where you think that a person might be perhaps a danger to themselves or someone else, or if the jealousy is becoming rather extreme and it's causing a lot of disagreements about trust and the like, that's when you're really going to want to bring a professional on board to help understand what's going on.
Thank you. Linda, did you have anything to add to that?
I did. I was, as being on the helpline, I will tell you that a lot of times we hear about some sort of episodic bouts of depression, where, because in Parkinson's, the depression is rooted in the disease. A lot of it can be rooted in the disease, the loss of dopamine being produced because there's less neurons there in the brain. So when you have more dopamine, you're going to feel better, or less, you might be prone to more episodes of depression, anxiety, etc. And so sometimes it can be helpful to observe when that's happening, and it might help even to distinguish between, is this something really, possibly just related to medications wearing on and off, or the medication itself. And the question about jealousy, with if somebody's on a dopamine agonist, jealousy and anger and suspiciousness can be part of the side effects of those medications for a small percentage of people. So I would say, keeping track of symptoms, like using a symptom diary, maybe even to help distinguish if there's a pattern to these experiences that people are having.
Excellent. I think that those are really good pointers. The next question comes from Ruth in New Mexico. how can I help my loved one with Parkinson's manage his depression? Now, I know you said that call a professional, keep a diary so you can see what might cause the depression or the other mood, but actually help us to understand how we can help them manage it once, let's say, we have the medications on board. Travis?
Yeah.
Linda?
Sure. I'm happy to get into this, and I'm suspecting that most everyone who is watching this webinar has heard that physical activity is good for you, and it's particularly good for Parkinson's disease. And that is certainly true. There's just more and more evidence pointing to the importance of physical activity, not just for maintaining overall health, but for maintaining mental health with Parkinson's. Another really critical lifestyle factor is being socially active. Whenever they've done these studies that have looked to see who does well with aging and who does not do so well, so we're talking about the MacArthur studies on successful aging, the Baltimore Memory Study, the very large study that Yale did, where they followed people for years and years and years through later life. The number one predictor of who does well is physical activity. And right behind that, even above things like genetics and other medical complications, is social activity, being socially active. And this is really important. There's probably a lot of reasons for it, but we do know that people who stay more socially active and engaged tend to weather the storms of life a lot better and to be more resilient to depression and anxiety and other types of complications that Parkinson's disease will throw at a person.
Linda, I know that you take calls on the helpline, and a lot of these follow-up questions, because this is the mental health panel, do in fact deal with depression and apathy. And what I'm hearing is a little bit difficult to put into play, says somebody who is a caregiver to somebody with Parkinson's. So for example, if someone is depressed or extremely apathetic because of either the disease or the medications, how can you encourage them to exercise? I have a hard time forcing myself to exercise, and I don't have depression.
Right, I can relate to that. That's a great question. There's sometimes a lot of benefit in scheduling things with others. With exercise, for example, if you can be a part of a group exercise where there's also going to be some socialization, and there might even be a little bit more incentive because other people are going to be wondering where you were, and you didn't come, and so there might be a little bit more interest and investment. I want to just add with COVID, this is the time to really maximize a chance to maybe invent new ways of talking to people, planning beyond COVID. This is, everybody's open, more open to talking to each other in different venues and forums, and you might be able to find yourself getting more socialization now that continues well after COVID. So maximize Zoom media and FaceTime and text people, and there's some great resources online where you can exercise with others, and so maybe that helps to offset some of that resistance too, because you could have it in real time in the comfort of your own home even. But structuring activities is one of the antidotes there to this. I remember Muhammad Ali's wife talking about how he had changed. He never needed to be motivated to exercise. And here she found herself sometimes having to work on this. And she found that when they had a schedule with other people, and sometimes if they were outside their home, which right now wouldn't apply with COVID, but when it was at another site, that they were more successful at getting things done. So, yeah.
You know, along with the idea of group activities, and it's hard to admit, but there might be a silver lining to COVID, and that is that you're actually reaching out to people that you might not even know. So you might develop more of a comfort level. But when you think of group activities, what kind of group activities would you encourage someone with Parkinson's to become involved in? Either one of you.
Well,
Go ahead. Go ahead, Travis. Yeah.
what I was gonna say is that the low hanging fruit here is the Parkinson Social Support Group. This is a great jumping off point, even for people who tend to be more introverted and a little less outgoing. You can show up there and you can jump right into the thick of it. Or you can sit back and be something of a wallflower. I've been to at least, I don't know, not quite a dozen, but close to a dozen different groups in the South Carolina area, and I've seen people kind of showing up and participating at many different levels, and that can be a really good starting point for someone who doesn't necessarily have a built-in network.
Right.
I think what I hear a lot of from my patients are people finding good community within their churches, because oftentimes there's a lot of opportunity for service there, even, whatever it may be, handing out brochures, helping with cleanup, lots of different levels to be involved with. And being involved with service also helps people get outside of their own head and add more meaning to life. So that's another one that I've seen work really well. And then, of course, you've got Rock Steady Boxing and these other kickboxing programs, which I think it would take more work to not find yourself interacting with your workout partners before and after the routine than to just go along and meet them afterwards for coffee and things like that. So I've seen that rock boxing model really, really help a lot of people expand their social support networks.
I would have to agree. This leads into two other questions that feed directly into what we've been talking about with regard to social interaction and also apathy. James from Oregon, for example, has to deal with the person that he cares for apathy. And Linda, I know you take a lot of calls with regard to how do I motivate my wife? How do I motivate my husband? And this is one of the problems that you have when you are a care partner to somebody with Parkinson's. So how do you get somebody to care when they don't?
It's tough, but it's doable. A lot of it in my experience has been, and I think Travis will be really great to add on to all of this, is finding out what brings them energy. What is their interest? What has always kind of perked them up? And you're on the right track if you're identifying the things that perk them up, and that's a good place, I think, to start. I think also to just planning, routine, structured activities, taking advantage of all those kinds of activities that might be in your vicinity, and maybe even being creative, maybe looking at some things in a different way, like a singing group. If you can find a singing group for Parkinson's, that's great too. So it's structured activity. Pardon?
Or start one. If there isn't one around, start one.
Start one. Right, exactly. And by the way, the foundation does have a lot of resources. We have a resource for helping people who want to start a group. So if a person was looking to do something like that, contact us. We'll see how we can help you with that. Yeah.
Right. One of the things that I could relate to was something Tate from Tennessee mentioned. And I remember when my husband was diagnosed, he tended to be more of an introvert, a CPA. And one of his concerns, and he always said to me, is that when you have the flu or a cold, you just don't feel well. When you have Parkinson's, you wear your disease. And that made him very, very uncomfortable with the idea of social interaction, because he felt that He looks different from other people. He's going to get some unwanted attention. And it was very difficult for me, who tends to be an extrovert and likes to socialize, to find a way to make him feel more comfortable about his difference, to get him more involved in conversations. Because when somebody with Parkinson's is speaking, their speech tends to be slower. Their brain might be racing and they know where they want to go, but their speech tends to be slower. It's difficult for him to break into conversations. And I know that that's something that Tate mentioned. How can she get her husband more socially interactive? And how, in fact, can she get people to stop long enough to listen to what he'd like to contribute?
Yeah, so I mean, I kind of hear about two separate things here that are both really pretty important. The physical appearance is the one, and then the communication is another. And so, I mean, unfortunately, it is true that we do judge people based on our appearances. There's no two ways about that. And we tend to make pretty snap judgments about people based on what we see. It's likely that Tate's husband may never be an underwear model again. I don't know. You know, there may be some changes that come with this, but I think it's also equally true that people tend to be more concerned about their own appearance than what other people are looking like. We tend to be rather narcissistic and be more concerned with how others are perceiving us than we are perceiving other people. And well, it's really hard to get someone to relax and feel good about themselves going out when they know that their appearance has changed. It's also true that people who do continue to go out and to continue to put themselves into social settings tend to relax more. In psychotherapy, we call this exposure. And it's really important to just keep putting yourself out there. And if you're really perceiving what is happening around you, you will notice that some people who don't know you may be perhaps a little standoffish, kind of wonder what is the shakiness about, what is the posture change about. But most people are going to stop thinking about that pretty quickly, and the important people in your life aren't going to really care so much about what your appearance is. They're going to care that you're there. When you start to see the anxiety about perception affecting a person's willingness to go out and to be involved, I think that's the time when psychotherapy is a really good idea, because avoidance leads to avoidance leads to avoidance, and people's worlds can contract pretty quickly. And we certainly do not want to see that happen in people with Parkinson's. The second half of that question is dealing with communication, and that's another really big one. And there are lots of reasons that I hear about for people kind of stepping away from interactions. There can be lots of reasons why. Apathy can be one, depression can be another. I like to kind of start at the root level when I hear about this problem and wonder, okay, is there hearing loss? When people are not, Parkinson's aside, particularly in men, hearing loss often comes up. When people are not hearing as well, they're much less likely to jump into a conversation because they're not quite tracking it so well, and it becomes easy to just kind of sit back and let that conversation roll on by and have one's own thoughts. So that's a great starting point. Once you rule that out, I think it's important to start looking at cognitive factors that could be in play. Is the person having a hard time tracking the conversation, tracking the thread of what's being discussed? Or are they having a hard time finding the words that they want to use to express themselves and to organize them and then put them in seamlessly into the flow of a conversation? This is often the case. And so from a care partner standpoint, what I found works really well is if people can sometimes slow down the pace of a mixed conversation where there's multiple people, and try to keep it on one topic so that it's not jumping from this to that to the other really quickly. Keep it on one topic, and then find a way to maybe dovetail the other person's particular interests into that conversation and invite them in and get them to be to participate more. And then the last kind of pro tip that I've seen work really well is just to reduce the size of the group. So if there's lots of people mixing and mingling and it's a little overwhelming, say at like a country club type of a gathering, go down to just getting together with one other couple or maybe two other couples, and go to a place where it's quiet, where there's less distractions, where it's going to be easier for the other person to actively participate.
Something more manageable
finally,
is what I'm.
Yes, yeah. I mean, there's an easy button there that you can press that can really make it easier for the person with Parkinson's to get involved and be active and to share their thoughts and feelings, which is, of course, what we all want. And then finally, you can't forget about speech therapists. If there's a communication issue, they're part of our allied team, and we want to make sure that we can use them to help with things like volume and speech and articulation.
Right, and that's something that Amy from Illinois talked about, which is she was having some difficulty getting her person with Parkinson's to actually continue with speech therapy or to exercise with boxing or anything else because of the apathy and depression. But I think we've addressed those. One of the things that I've heard is that people with Parkinson's sometimes tend to get very angry. Personally, I don't know if this is due to the disease or the medications, but anger and irritability are sometimes the cornerstone, the touchstones of Parkinson's disease. And when you try to use your own skills to manage the person who is angry or irritable, it usually backfires. In the case of Jane from Illinois, she said that her husband is constantly accusing her of trying to act like a counselor. So she doesn't really know how to deal with this. Linda, I know you take calls like this on the helpline. What advice can you give her?
Well, I think it can depend a lot about what that anger is about. If the anger is something that might seem a little bit unusual for him or her, that maybe there's something more going on that has to do with changes with medications or changes with the disease even, or even if there's some information that recently they came across that's just kind of, perseverating, just going around and around over and over. So I'd want to identify really, in my experience, I talk to people about, what's changed when I'm on the phone. When I talk to people, I just kind of like to get in the here and now sometimes, and just, what's going on now that this is really kind of flooding you with difficulty. And so I think that's very important. Anger, is sometimes anger is just the flip side of it is hurt. I think you can say sometimes anger is just hurt. Talking to people, and Travis will probably be the better person to talk about how he digs into that, but what that hurt could be about, and trying not to sound like a counselor, which sometimes it might just sound psychologically, psychobabbly to say things like, repeating what they're saying to make sure you understand what they're saying. And we practice this even in our own relationships and our own families. That's kind of the ideal way to converse anyway, is to hear and then repeat. Do I understand that you feel this XYZ? Do I, and then that doesn't mean that you don't completely disagree with them and that doesn't completely, irritate you, but still just acknowledging it so they know that you've heard them. I think that's a really important part of it, that they know you got what they're saying, and not saying it in a way that sounds rehearsed, but just, did I hear you say that you feel, blah, blah, blah when I do blah, 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 or is that what I'm understanding you to say? And then I think that's a good way to address some of that anger. And then maybe look at other things, how did they sleep last night? How has their sleep been lately? And I also think there should be, like, we ask about sleep hygiene. I think there really should be a socialization hygiene kind of question that gets asked a lot, that should be really on the forefront of our thoughts about, because like what Travis was saying, it's like, if you're not socializing, you are really going to be prone to depression and anger and hopelessness and a lot of things. So I think really digging into a little bit of that too, because maybe the care partner is the only person that person with Parkinson's is interacting with. So, that could be part of the solution too, is to involve more people in his life.
Good point. One of the questions is, Travis, I know that you've mentioned a few times that it's time to bring in a mental health professional. My first question, and it actually came from, give me 1 second, Walter in Tennessee, wanted to know how and when should we bring in a psychologist or psychiatrist as part of the care team. And what I wanted to ask is that for many people, it's unaffordable. Their insurance doesn't cover a psychologist or a psychiatrist. So it's a twofold question. When do you bring somebody in? And if you don't have the financial wherewithal, how do you bring them in?
Yeah, that is a tough one. I'm not as well versed in how to navigate the insurance system in order to get these kinds of services covered. I know that with Medicare Part B, which should be pretty much the same across the country, there's 10 individual psychotherapy sessions that are covered per year. I would not be able to tell you whether there's a copay or not, and really every healthcare plan out there is going to be different. So the financial piece is tough. I think the other part that's really tough is finding someone good in the community who understands enough about Parkinson's to really provide good, informed therapy that works. And one of the things that I always tell people when I'm recommending a therapist and describing what the empirically supported type of therapy, which is primarily cognitive behavioral, what it's supposed to do is that it's not supposed to make you comfortable. It is supposed to challenge you to do things differently in your life so that you're not repeating the same patterns of behavior and the same patterns of thinking that have led you to a negative place, or in other words, have been kind of maladaptive. So it's sort of like going to a gym. If you go to a gym and your muscles don't feel at all worked by the time you're done and you just feel nice and relaxed, you probably didn't get a workout. And the therapy really should be a challenge to change. And I think that in trying to find someone, it's critical to find someone who really is going to push you to do something differently so that you're not just venting and kicking a can down the road for months and months or years and years without actually making some of these changes that we know can really work against depression and work against anxiety.
Thank you. Linda, I'd like to switch now a little bit to care partners because the people in our audience are the care partners. And there are two questions that I think dealt with this most. And one was from Kristen in Ohio, and she wanted to know, what are some of the coping skills to deal with care partner guilt?
Yeah, guilt. That's a heavy feeling. I think a lot of it is about being your own friend and being, knowing that you have, you're sharing, you and your the person that you're caring for with Parkinson's. There might be some parallels, with what you both feel. You might sometimes be going through things very similarly at the same time. And you're really, good to get in the practice of protecting yourself from guilt by giving yourself, a little talk saying, not every day can be a good day for me. Not every hour can be a good day for me. I'm going to do the best I can with what I have at the given moment, which is one of my favorite mantras to follow. And also, try to look at prevention in this too. How do you prevent that guilt from building up? So, I kind of look at some of this like the way we do with taking care of our cars, the maintenance we do on our cars. And I think that we have to do maintenance on our feelings and try to prevent things from getting too far. So I say that's where, again, it comes into the points being made previously about connecting with other people, about what your experiences, other care partners, other family members. Don't isolate yourself from in this experience. You're all working on this together. Seek help when you need it. Have breaks for yourself. Give yourself your own rest time that you can count on. Is there people that can come in and help you to maybe delegate some tasks to some other people so that you can have a definitive time where you can have a mental health break or physical break. So doing these things that take care of yourself are really key. And with guilt, the flip side of that can be anger. You can have this anger and guilt kind of thing that you go in between. And being communicative with other people, perhaps in counseling or friends, I think is a really big part of that. I don't know, Travis, do you have anything to add to that? Did I miss anything?
The one thing that I might suggest is, as well as what you mentioned about providing time for yourself and seeking professional help when necessary, those are critical. I think the support groups are another really good resource, because there you're going to hear people describe many of the same struggles that you're going through, and in hearing that, it can take away some of those feelings of guilt sometimes for some people. One of the sad parts of Parkinson's that I've seen occur over the course of illness is when a person is no longer able, the person with Parkinson's is no longer able to really go and participate in these support group meetings for whatever reason. And so because of that, the care partner no longer goes. And that can be really unfortunate, because the care partners are oftentimes getting quite a bit from those support group meetings. And we always really try to encourage care partners of people with more advanced Parkinson's to keep going, because otherwise it can be really isolating, and they can feel like the emotions that they're having as they try to work through everything, maybe, or there's something wrong about them, and they just don't have that same sounding board that they otherwise would have. So we really try to encourage attending those support group meetings, and when they're available, we now have a care partner support group as well to make use of those. They can oftentimes be a lot better than seeing a specialist or an outside therapist.
Right. And I think that what resonated with me about this is that a lot of times I think the guilt that a care partner might feel is, I didn't deal with this well. I didn't handle this well. I lashed out in anger or frustration. And some care partners become bitter. This was not what I expected out of my life. So it resonated with me that it would help to hear other people say, I felt this way also. And like Linda said, we can't all be perfect all of the time, just to paraphrase a bit of what you said. One of the things that came from Ellen in California is, and again, I'll direct this to Linda initially, because Parkinson's disease is progressive, we often must think of the future, whether we want to look down that hole or not. And it can be very depressing. I've heard some care partners say that they wake up in the morning and there is a cloud over their head, even if it is a beautiful sunny day. And then the care partners become stressed and anxious. And frankly, we've all heard about self-care and we've all heard about meditation, but do you have any advice about staying in the present, Linda?
Yeah. It's to me, staying in the present is really kind of a very much more natural thing than we may think of it. But I try to really think in my own life, actually, in with a lot of conditions that I've been versed on, that you just don't know what's down the road, good or bad. We just don't. And so when you start thinking down the road, and that happens sometimes, sometimes we tend to catastrophize things, and we just create a pile of worries and fears, and we're really focused on those, and they're all kind of in the future. And so the idea of mindfulness, I'm sure a lot of people have heard about that. It's a practice. It's a practice you can hone in on, where you can be conscious of the moment that you're in, and be conscious of what you're feeling and thinking, and be also coaching yourself with some phrases like, I don't know what tomorrow will hold. I don't know what's going to happen. And also to look at the meaning of what means things to, what is meaningful for you today. Excuse me. What provides you the energy today, and focus on those things. Like if you really, enjoy those grandchildren, then really live in the moment with those grandchildren, those pictures you might have, or the videos, or just talking about them. You really enjoy today and what's in front of you today. If you're having a hard day and you can't get past that, you just try. You make your efforts to do that. But there's a lot going on in the future, things that we can't predict. And even today, we can't even completely predict what's going to happen. So try to stay in the here and now, and look at the things that energize you, and choose hope. And when you're not feeling like you can choose hope, just think the thought. Just think the thought, and train your mind to think about these things that are going on today. And also, I wanted to say one other thing. Try to have an input of a balanced input of what goes in your ears. Like the news, like if you have that news on all day long, for example, which is really hard with COVID, I think, is to try not to do that. Just have a 1 or 2 shots a day of news, maybe. And then look at what else are you listening to? Are you connecting to the things that are meaningful to you? Like if it's a spiritual belief, or if it's some kind of interest you have, are you connecting to that? Do you have more of that in your mental account than you do of the negative that you have in your mental account?
That's true. That's very true. Travis, you mentioned on a few occasions the importance of getting a psychologist or a psychiatrist involved in the care team. How do we find a professional, either a neurologist or a movement disorder specialist? And this came from Diane in Texas, somebody who is well versed in psychiatric and psychological aspects of Parkinson's disease. How do you know who to go to?
Sure, and just to be clear, I don't think that everyone needs to be seeing a psychologist or a counselor. In fact, I think at any given time, most people don't need to be seeing a psychiatrist or a psychologist. It's important that they're there for when they are needed. In order to find someone that's good, the best recommendation that I would have would be to look for a center of excellence near you. It's a great starting point. It doesn't mean that there aren't great people who are not at these centers, but it's a great place to start because they've already really been vetted in a number of different ways. And there's a very, very high chance you'll find someone who is quite skilled and versed in the non-motor and psychiatric aspects of Parkinson's disease there. If that's too far away, perhaps you might travel there at a certain basis, and that movement disorder specialist at the center will work in concert with the more local neurologist that you're seeing. And if they're really too far away, you might ask for recommendations. The people in these centers are going to know people who are out in your area, or at least there's a good chance they'll know of someone who is practicing there that they think highly enough of to try to manage these complex psychiatric things that can go along with Parkinson's disease. That would be my first recommendation. The other thing that you can do too is, again, I'll just throw up the support group idea around. So at the support groups, people talk. There is going to be at least one person there who has struggled with mood and anxiety symptoms, and I certainly hope that there'll be also at least one person there who has found someone who has been helpful that they can then recommend. And really, you're doing a favor in several ways if you've stumbled upon someone who has been very helpful for you in managing the stuff that the depression, anxiety, maybe even the psychosis that can go along with Parkinson's, and you send someone else to them. They're more likely to benefit by seeing that person than just a random name out of the phone book. And that person is going to build up a skill set as they see more and more people in the community with Parkinson's disease. So you can really kind of build an expert in your area that way.
Grassroots training.
Yes.
I just want to add, Travis, I think that was just so great what you said. I want to add that, sometimes a particular unique problem might come up with Parkinson's that the therapist or counselor might not know about. And the foundation has information. Sometimes people will say, do you have something that I can give my counselor or psychologist or whomever to talk to them about impulse control disorders in Parkinson's, for example. So keep that in mind too, that if maybe working with a counselor who's maybe they're not fully versed on Parkinson's, but maybe they're open to learning, and we can help with a lot of information if you think there's a need.
So
yes, absolutely. I was just going to say that's a great tip, and what you said about kind of arming that person that you're going to see with some information they might not otherwise have is a really good idea. And the vast majority of therapists are going to be quite receptive to that information. They're in the business because they're trying to do right. They want to do a good job, and they'll be very interested in that information that can be provided. That's been my experience. We try as much as possible when we do refer people to the community to not just kind of send them out, and say, good luck, hope for the best, but to really try to make it a more warm handoff to that community provider so that they know what they're seeing and what the issues are and what we're hoping they might help that patient address. And so the patient can be certainly proactive in that role by providing foundation materials to get off to a running start.
And Linda, that's something that you do on the helpline, the Parkinson's Foundation helpline?
Quite a bit, because really the odds of every counselor that's out there being 100% versed on everything that's going on medically, for different conditions is pretty low. So I think you could, I don't know, Travis, if you think this is true, but I think you can probably presume that many of them don't have they probably have a sense of things, a natural sense of things, but the full idea of what happens in Parkinson's, especially those non-motor symptoms, which is these mental health problems that can come up and they can sneak up on people, and they may not know that there's some, pathology, some medical explanation for some of these things.
Yeah, it's really challenging. If you didn't know anything about Parkinson's, how would you know what was going on with this wearing off anxiety, in the late afternoon when our circadian rhythms take a dip and the medication tends to wear off? There's nothing in your basic training that would prepare you for trying to understand that or to understand what's going on with these impulsive and compulsive behaviors. And even really just the neurobiology of apathy and not having this normal motivation to do and to seek out and pursue interests. So dopamine is a huge part of that. That's how we predict something being a rewarding experience. And when dopamine is low in Parkinson's, which it is, it's not just low in the motor circuits, it's low in the limbic pathway as well, and people make these reward prediction errors. And we can treat reward prediction errors, and we can address apathy more directly by doing some rather simple experiments that these therapists would be have been doing for a long time in CBT, where you make a prediction about how much you're going to enjoy something, you force yourself to do it, and then you rate your level of enjoyment and see whether your prediction was right or wrong. Most of the time it's wrong. The people end up enjoying things more than they expected, but the next time it comes up, they completely forget what they've learned, and all they see are the obstacles to doing whatever it is, the drive, the cost, whatever it may be. And they underestimate how much they'll enjoy it. And so if you can be aware of something like that, this kind of phenomenon that happens in Parkinson's disease as a therapist, you can right away start doing some important behavioral work to change these patterns. And many therapists will want to do that if they're just given some of those insights on how to work with it.
Thank you. There are just two. I wanted to clarify. CBT is cognitive behavioral therapy, correct? Okay.
That is correct. Yes.
Okay. Two questions, and then we'll end it here. This one has to do with sexuality. I know that many people are very uncomfortable asking questions about sexuality, and when you have somebody with Parkinson's, and this does come from Norma in Georgia, it's not always that somebody is unable to perform, but sometimes it's that the person with Parkinson's can perform sexually and wants to spend hours having sex, but has a problem with being too tired when this particular caregiver would like to enjoy other activities. So two questions, and is hypersexuality something that you see frequently in people with Parkinson's? And how do you suggest that the care partner handle it tactfully?
I can start with this one. So hypersexuality, is it something that we see frequently? Not exactly. It is an impulse disorder, and it oftentimes comes up when people are taking a lot of medication, particularly the agonist type of medications, this hypersexuality, and it can certainly be a problem. A lot of what we hear about are excessive looking at pornography on the internet. That's become kind of a big one, and sometimes it can be hypersexuality within the relationship. And so really the first stop in this particular situation would probably be a revisiting of the medications, and perhaps if there is a dopamine agonist on board, trying to move down off of that. And the other thing, of course, would be, I think, looking at some marriage counseling, and to try to see, why is it that person is so hung up on sexual intercourse, as to the neglect of other things. I'm hearing a lot in that question that really suggests to me that there is a neurobiological dopamine dysregulation thing going on in that particular one. And before turning it over to Linda, just to speak more broadly, I mean, sex is important. It doesn't stop being important. Sexual intimacy is important. It's healthy. It's good. It's a very important part of life and relationships. And I do hear a lot about various types of sexual issues that can come up. I work with a number of women neurologists, and so when people see me, that's when men particularly see me, that's their time to start asking me a lot of these questions. And I think that it is important to do the kind of couples work, whether it is involving marriage counseling or something else, in order to preserve a healthy sexual relationship.
Thank you. Linda, did you have anything to add to that?
I was just going to add that the same thing. It kind of sounded like we get a fair amount of questions or calls from people who are in the throes of impulse control problems with dopamine agonists, because there's a lot of shame and embarrassment, and a phone call is sort of protects somebody's identity a little bit. So they'll call and they'll tell us what's going on a lot. So we do actually get a fair amount of calls like this. And what I can say is that that was the first thing that popped out of my mind. And I think one of the things that might be one of the telltale signs that it could be is that is the person pressuring you? Are they getting agitated, because you're not meeting their need? Does it feel like it's all about that and there's nothing else, nothing else part of it that matters? So I would say, just as if you were counseling your own best friend, when somebody is pressuring you or making it an uncomfortable experience for you, then that's probably a good tip that it might be a dopamine agonist. And then one other thing I wanted to say about that is that some people don't maybe know that some of the side effects from the ICDs of dopamine agonists don't happen right away. So it might be 8-9 months from when they started taking it that this actually develops, or sooner, but it doesn't necessarily develop right away. So you may not connect the dots to it being a dopamine agonist if it is. And then the other thing I'll say is whenever there's a problem for anything with Parkinson's, which is probably what everybody's doing anyway, is you're looking for what's changed. Has it always been this way? Or why now is this happening? And try to think back, what could be, what could have happened that started all of this? So yeah, that's kind of what I would suggest.
Thank you. The last question has to do with young onset Parkinson's disease patients. And the question comes from Grace in California. How can we as a community increase the awareness of the unseen mental and psychiatric side effects of both the disease and the medications among young onset Parkinson's patients, their physicians, their families, and in the workplace?
So, I sometimes think that, all right, so you have disease, right? You didn't choose it. And now you're kind of an ambassador. You're not by voluntary choice, but you are a bit of an ambassador. So I guess a person could benefit from deciding, all right, I am going to be in situations where I'm going to have to advocate, even if I don't want to. I might be advocating for myself. And sometimes once people cross that threshold of getting past that point that, okay, I didn't want to be this, but I am this, they start to just embrace what they want to do. You kind of get a hold of that fire in your belly about what you want people to know. And you're going to want to think about things like using good judgment about when and where to talk about the disease with people. But you might want to start practicing with the people, the safest people around you, and then expand it a little bit and start talking to other people you don't know as well, and just kind of, build your comfort level by practicing with other people. Now the foundation, we have a lot of support. And by the way, there's up to 1 million people with Parkinson's. So you are not alone in the true sense of the word. You are not alone. So there's a lot of people that probably have some connection to Parkinson's, and talking about it may not be so, uncomfortable as you might think it is too. So, and you have, 1 million people who have it, and you have all the people who are connected to those 1 million people. So there's a lot of people to fortify you as you advocate for yourself, and you can do it. You can do it. And we have information again on the helpline to help people with. We have some stuff on our website about how to talk to your employer, and other kind of tips like that. So reach out to us and we can give you some things that are very specific to your situation to help you with this.
Thank you, Linda. On that upbeat, positive note, we're going to end today's discussion. I'd like to thank the audience participants for providing such thoughtful, sensitive questions, And both Linda and Travis, thank you so much for your responses. I think that what you've said has given us all food for thought, and I think made us believe that we're not as alone as we might feel. So thank you again.
Okay. Thank you.
Thank you for the opportunity.
Yes, thank you very much.